Hello, Renato, do you hear us?
I'm hearing very well, Professor Seitz. Good to see you.
So you are in the middle of the night. What time is it in Brazil?
Not so much. It's early in the morning. It's 7:20 around that.
Okay, that's okay
It's
for
early
you.
in the morning. It's fine.
So we
It's
only
a
half an
little
hour
worse for my
behind. So we are looking very much forward to your first international keynote lecture on the enhanced ectasia diagnosis, the role of artificial intelligence, and multimodal corneal imaging. It's your turn, Ambrósio.
Thank you very much. It's an honor and a pleasure to participate with you. I wish I was present with you guys in Germany, but I'm honored to participate from Brazil. These are my financial disclosures, of course, including Oculus, the company with which I have the privilege to collaborate within about 15 years. I also welcome you to the International Society of Refractive Surgery, leading network for cataract and refractive surgeons. Uh, and I also work with the Brazilian Artificial Intelligence Networking in Medicine. We completed 10 years last year, and I included a masterclass course which has over 20 hours of talks and lectures on multimodal refractive imaging, which we'll dig into this talk. I start with some wisdom. We have to understand that we need to understand ourselves. We have to be aware what we are trying to do in terms of ectasia diagnosis. Screening and early diagnosis is different than giving prognosis for the patient, is different than classification and staging the disease. It's important that we have data for follow-up and also to guide the patient, to educate the patient about what they need and they should do. And of course, the data that we have from multimodal imaging will be important for us for the treatment guidance. Refraction can be very much optimized if we have better technology like the wavefront. And also we have different tools for adapting custom contact lenses and of course planning complex surgeries. A very important question is topography enough? And I have come with a very interesting example from a physician who has contact lens warpage. She can be detected as contact lens warpage based on the integration of tomography and also biomechanics. Interestingly, she also has dry eye. So this very interesting female, she is a contact lens intolerant. She has dry eye, and dry eye is the cause for her contact lens intolerance. And we can also correlate the tear film breakup time with the scatter index from Roger Zaldivar, who did a very nice work on the stability of the quality of the optics. But it's very important that we look at this cause, why this patient is having a problem with her contact lens. And if you see any very good cornea specialist will look in the margin of the meibomian glands. But if we have a better imaging, you can see that the meibomian glands is really not on the edges, on the clods that we see in the peripheral. But if you see this image now, you can see how the lens is looking at the slit lamp regularly. So it's important that we look at the multimodal imaging that we have with the topography. But looking at the evolution of corneal imaging, placido disc topography was very important for all of us as refractive surgeons. It is a very nice review that has Steve Kleiss and Steve Wilson that looked at the future, and pretty much we are living this future, that looking at the ways we do with customized topography guided refractive surgery, not only for elective procedures but for therapeutic procedures. I was very honored to do my fellowship with them, and we looked at the importance of topography because we have patients with 20/20 and 20/15 distance correct vision that will be detected based on topography, and we need to go and understand the relevance of corneal topography. It's important that we go beyond the surface, and if you want to, for example, classify diabetic corneal disease in terms of pellucid and keratoglobus, you need data beyond the surface. Of course, The slit lamp is fundamental here, but we need to understand the importance for looking at the thinning pattern and location of tomography for understanding it. And in the global consensus, we were very keen to identify the classifications and the definitions for pellucid. And there are cases that we can eventually call pellucid based on the front surface topography. And Michael Bellin is one of the most prolific authors on this, that we have to distinguish between inferior keratoconus from a case of a true pellucid, in which you have the band of thinning without opacity in the inferior part. Very importantly, pellucid can also occur superiorly very rarely. But the point is not only to classify ectatic disease. If you want to look at the screening for ectasia, for example, for ectasia risk, topography will come in the top of the list. But I would say it's not a very good idea to consider abnormal topography as form-fruit keratoconus. Importantly, this work by Rendemann included age, which is a surrogate of corneal biomechanical properties. So we need to go definitely beyond. It's important that we are keen to identify the clinical topographic patterns in which we have to see what is normal, what is a symmetric bow tie, the bow tie with the symmetry, with the skewed axis. And of course, I think form-fruit keratoconus is a misleading concept as a topometric classification. It's interesting that we review the history of ectasia. The first report of ectasia was published in 1998 by Professor Seiler. He published 3 cases of progressive steepening on patients that had high myopia treated by LASIK. Myopia very high. Today we don't do those surgeries anymore, but the weakening caused by the procedure made the cornea unstable. A few months later, he also published a form-fruit keratoconus to have progressive keratoconus, and he published form-fruit keratoconus based on the inferior steepening, which, if you see the Brad Rendemann classification, would not be a form-fruit in his classification, would be probably inferior steepening, possibly with some skewed radial axis. But if you look at those 2 cases, the pathophysiology of ectasia are perfectly detected there. The corneal resistance, the innate biomechanical properties, and the impact from the environment. The impact from the environment is related to laser vision correction for sure, but eye rubbing is probably the major cause to have the cornea develop ectasia. And a very important concept to consider is that any cornea may develop ectasia. That's why we started a campaign, the global campaign for keratoconus awareness, which I invite all of you to participate, the Violet June. We started in Violet June, and now we are waiting for the November 11th, when we have the day of keratoconus based on the Keratoconus Foundation. And I think it's very important that anyone understand that eye rubbing is bad for you, should not rub the eyes, but any cornea surgeon should be humble to understand the difference between eye rubbing or scratching the eyes or sleeping over the eyes aggravates keratoconus, and it may even cause ectasia, which are different things. So when we look at the risk factors for ectasia after LASIK, we have cases with normal topography and tomography, and we also have cases with abnormal tomography that had stable LASIK. So we have to understand sensitivity and specificity, and I think a major concept is understanding what is form-fruit keratoconus. We know form-fruit keratoconus is not exclusive for keratoconus. We have form-fruit psychosis defined by Freud, for example, and many colleagues like my friend Yaron Rabinovich would say that a form-fruit keratoconus differently than others. The concept is that form-fruit keratoconus is a mild disease, but Yaron Rabinovich would say that a patient that has abnormal topography with a 20/20 distance correct vision normal slit lamp will be form-fruit keratoconus. Steve Kleiss, in a very nice editorial from 2008, he would say that the fellow eyes with normal topography will be form-fruit keratoconus. I will call those cases very asymmetric ectasia, and we have learned tremendously from those cases. My friend Damien Gatinel from Paris, France, he has a very nice understanding on the topographic criteria. And if you see, the form fruits keratoconus are still on the topographic normal criteria. So they overlap with the normal, and we definitely need to go beyond the surface to understand it. And I really resonate with this concept. Of course, keratoconus and normal should have a sharp edge, but it's not so sharp like this, and you have the suspects. And we have to be keen on understanding on what is form fruits, what you're trying to achieve in terms of the definitions, in terms of what you're trying to achieve in terms of the diagnostics. A very nice systematic review from Maria Enriquez from Peru. She did a very nice work on the literature review, and she found no consensus, a huge variability. And that's really resonates that we don't have a consensus based on the definition of form fruits keratoconus in our global consensus. And my humble contribution is that it should not be a topographic classification, but defined as a cornea with a high susceptibility for ectasia progression. So I would say that form fruits keratoconus is like a misleading term. Fruits means crude, incomplete, confused, but the fruits keratoconus is a cornea with susceptibility, and I think we should objectively look at the susceptibility for progression. I look at my records, and I found this proof of presence in the American Academy of Ophthalmology in 2008, in which I presented tomography and biomechanical concepts for biomechanical susceptibility understanding for ectasia. And this was one of the cases that we were debating on that time, a patient that had LASIK with no risk factors, PTA lower than 0.4, nice contribution by my friend Marconi Santiago, and the patient has ectasia. And a lot of people would say this little yellow here in the Steve Kleiss and Mike Smolik scale will be a pathognomonic of form fruits keratoconus. And I was really frustrated. I was really frustrated with this. And we started a study on the variability of subjective classifications. And this was patient that vary from 0 to 4 and 0 to 3 on the two scales that we sent for the study. And in this study, we also found a huge variability on the subjective classifications, with 9 of the 11 classifiers changing their classifications on the two scales. So we need to go for objective metrics. That time we were talking about the importance of words. Words matter. Corneal topography is different than corneal tomography. Front surface evaluation versus the three-dimensional reconstruction of the cornea. And one is not to replace the other. We just talked about the importance of looking at the tear film, but we need to objectively look at the tomography data, and that's how we developed the Belli and Ambrósio display, in which we combine tomography and biomechanics, and the D in this patient was higher than 1.4, 1.5. The threshold will be like a sharp threshold, but the threshold to identify ectasia susceptibility. We can consider age, we can consider the impact from surgery, and also the arc max will be important here. Another very interesting paper that was published on the first report on ectasia after SMILE. SMILE has a biomechanical advantage after LASIK. Yes, it has. But the SMILE also weakens the cornea, and I think it weakens. Actually, it's pretty well established that it weakens a little more than PRK, than surface ablation. But this patient was developed ectasia after SMILE, and the patient has ectasia prior to surgery. It actually, about 10% of the clinical keratoconus cases that we have in about 2,000 patients, they have what we call as low K keratoconus. And for classifying the low K keratoconus, you need to look at topometric data, tomographic data objectively. And interestingly, this is low K because the K max is lower than the 46 range. Interestingly, we have to look at objective data, and the objective data will be very important for us to look also at the specificity. I have a few cases to show you. This is not from my clinic. This patient was part of a database of enhanced screening for ectasia risk, and this patient had LASIK also in 2008, and the patient did very well, and she is still stable. And retrospectively, we were able to look at tomography because we didn't have the Belli and Ambrósio at that time. Interestingly, a very large study with 3,278 stable LASIK and 105 ectasia cases. You can see the IS value and the Bell-Ambrósio D. The Bell-Ambrósio D does more sensitivity than the IS value, but is still lacking some work. And this where my friend and colleague Bernardo Lopes did a great work on his PhD thesis, which I had the privilege to collaborate, and we looked also at the artificial intelligence ability to help. We have to train, and for training artificial intelligence, you need to train what is the disease and what is the non-disease. If you train the disease and non-disease well, looking at good parameters that are accurate, we can combine those with artificial intelligence and have internal and external validations so that we have a clinical implementation. So in his work that he published in the American Journal of Ophthalmology, the enhanced tomographic assessment for ectasia susceptibility, we included patients that had fellow eyes with normal topography and 60 of the 105 cases that had ectasia after LASIK, in which we had the pre-op data. And we have the Pentacam Random Forest Index, which made a huge step, in my opinion, for improving the sensitivity and specificity. But you still see some of the red cases down below, which make the point that we need to go beyond the surface towards biomechanical understanding. We have the biomechanical characterization of the cornea as the next step, and this is interestingly seen by this nice editorial and review by Cynthia Roberts and BJ Dupes. And the biological properties will be divided in corneal wound healing, which Steve Wilson is one of the most prolific authors on this. And my quote is for my friend Carrobel Oliveira from Brazil, and he says that the bioelastometer is a measurement of the past from the times of arcade that we never had. We have worked with different machines like the ORA that I saw in the previous presentation, but since 2009 we started working with the prototype of the dynamic shine fluid imaging. The Corvus gives you 140 frames in 31 milliseconds, and we can characterize objectively how the cornea is deforming. And the very nice collaboration with Paolo and Riccardo Vinciguerra from Italy, we had combined the data for the CBI. And it can be objectively seen a cornea that has a softer behavior and a cornea that has a more stiffer behavior in terms of how the cornea deforms and how also the cornea has in terms of spatial profile for the horizontal thickness of the progression in terms of the pachymetry. Our work has been always focusing on combining data, not only tomography and biomechanics, but we have other data like wavefront data, and eventually epithelial thickness can be integrated. Even the axial length can be worked. And the maturity of the work comes from understanding the need for combining the data, like in the Bell and Ambrósio display, which I was really humbly honored to collaborate with Michael Bellin, and the ARV display, the Ambrósio Roberts Vinciguerra display, in which we have now random forest index. This work was done based on a multicenter study, my clinic and Paolo Vinciguerra. We had 94 cases with normal topography, and normal topography based on a strict objective criteria, KISA, IS value, central K, and we have a very nice separation for the clinical keratoconus, the 204, one eye randomly selected from this population, and 480, one eye randomly selected from keratoconus. And we have to see that this is maybe the first step towards the characterization of ectasia susceptibility, like an epitome for ectasia susceptibility. The concept that ectasia can be unilateral is important. This is one of the best examples. The patient had a very good result with a corneal ring in the right eye. The left eye is 20/20 plus since the first time I saw this patient. He moved to London and I have him seen my friend Dan Reinstein, Professor Reinstein from the London Visual Clinic, who has a prolific examination capability. And Dan was keen to do his epithelial thickness, which came normal in the left eye, and also Damian Gattinel Lançad's core analyzer. Everything was normal. And interestingly, when I did his surgery, we did not have the TBI, but we had the data, and we can get the U12 files and recalculate the data, and it was 0. And he comes back a few years later, and he's still very stable in the left eye, doing very well. And this is unilateral ectasia. We can have both eyes, though, with form-fruit keratoconus, and this is also the best example. The subclinical keratoconus in both eyes of a twin sister, identical twin sister, and you see the topometric map from the Pentacam and the Keratograph 5 exactly identical using the same scale. Of course, the scales are very important. If you want to compare topography from Placido and Scheinfeld, you need to be keen to analyze under the same scale. These 4 eyes have a TBI higher than 0.3, 0.4, so that both eyes in the second twin sister with a normal topography will be interestingly seen as form-fruit keratoconus. And interestingly, this patient also had a genetic evaluation by the Avegene test. The first result was that they were really twins, and I joke with them, this is not a very interesting data because we know that. They know that since they were born, but when they had some genes to be tested, they were able to identify some ectasia susceptibility. Also, we have cases like this one, the fellow eye of a patient that has keratoconus with a normal topography, normal tomography, and the TBI can be a little bit abnormal. And these are the cases that we want to detect. And of course, those cases are the ones that we want to separate if the patient has form-fruit keratoconus in the fellow normal topography eye, or if this patient has a normal eye from unilateral ectasia. I used to think it both possibilities, one or the other, but I think it's like a consensus that we have ectasia. You can have unilaterally, and I take this wisdom from Yoda, from Master Yoda, that we have unilateral keratoconus as something that does not exist, but secondary ectasia may be unilateral. It's important that we can say it's not one or the other, but like a threshold, a continuity. But going to a deeper wisdom, sometimes we have to be humble and see that we know something and we think we're right, but if we know more, we get to be really sure that we are wrong, that we were wrong. And we have to look at the literature, the recent studies on the TBI that were published, some of them also from Professor Seitz and others like Dr. Shizuka Ko from Japan also published on this, colleagues that I really collaborate with, and we have to get this data as opportunities to improve. And I think refractive surgery has made us improve our ability to treat keratoconus. This is making like a revolution in evolution, a continuous evolution that comes with artificial intelligence. And we had a multi-centered study for the TBI that we had expanded from 94 to 551 normal topography eyes. And those cases, if you see the Bell and Ambrósio D, they fall very well on the literature. The D is very good for detecting the clinical ectasia cases, the fellow eye with ectasia, the VAEE, and the keratoconus cases. And those cases, the normal topography eyes will be hard to detect with the tomography. So the AI optimization was done with the work from my colleague and friends from the Brain Group. And we have here the RSF4, which is the TB, which is coming soon, available in the integrated Pentacam Corvus software. And we improved the sensitivity for even for the clinical cases, but the most important one was to improve in the VAE cases, that we improved 10%. So I think we still have 15% of the cases that are like unilateral ectasia cases, but eventually some of these cases can be improved on the diagnostic ability based on more data like epithelial thickness, Bowman's layer thickness, Bowman's curvature, and other parameters like axial length, the relation between ACD and whole eye axial length. So corneal imaging for the refractive surgeon and for the refractive therapeutic surgeon that treats keratoconus, we have to understand what we are trying to achieve and how. We have to understand that topography is still important, especially if you have the ability to look at epithelial surface with the tear film analysis, and of course multimodal imaging with OCT, corneal biomechanics should be integrated to tomography. We have, of course, other applications like astigmatism, and we have plain laser vision correction and evaluating the results. But it's important that we have our minds open, that we have to be really going beyond the surface, but not forgetting the tear film and the ocular surface evaluation. So thank you very much for your kind attention. I really look forward to great discussions that we have. Thank you.
Renato, thank you very much for this excellent overview on the multimodal ways of diagnosis. So you also agree that there is no unilateral keratoconus, is that right?
Absolutely. Actually, sometimes I was thinking that we may have, we of course may have unilateral ectasia as I demonstrated, but the challenge is we may have bilateral ectasia. And those cases are the ones that are hard to distinguish between regular keratoconus and not.
Are there questions from the audience? You can ask in German. I try to translate if you want. How long do you live, Renato, how long do you leave the contact lenses out before you decide whether patients are eligible for refractive surgery?
The golden rule is 3 days minimum for a soft contact lens, but I prefer a week. And if it's toric, soft, I would say at least 2 weeks, rigid gas perm a month. But sometimes it's challenging. And epithelial thickness may help you tremendously evaluate if the patient is with any kind of warpage. But 3 days and three weeks are the classic time frame that I had since my fellowship time.
Do you have experience with Dan Reinstein's high-frequency ultrasound epithelial measurements and the implications for keratoconus detection?
No, I don't have experience with the high-frequency ultrasound, but I have used the OCT, the RTView OCT since 2013 at my practice, and it opens the horizon for understanding of the cornea. We have different OCTs that can do epithelial thickness, and even the RTView has improved from 6 to 9 millimeters, and we need objective data for those evaluations. But for the high-frequency ultrasound, I think the most important indication today is to look behind the iris, to see behind the iris, to evaluate the sulcus to sulcus, considering if you were planning for phakic IOLs in the posterior chamber, like the ICRIL, phakic, or especially the ICL.
Thank you very much. Any questions from the audience? From the 600 listeners in the internet? No? So, Renato, thank you very much. And then we hear you later on the same excellent talk on stage-appropriate therapy. So we see you back in a second.
Thank you. I welcome my colleague, Dr. Barron.